First of all, I would like to thank you all for setting up this important day for pediatrics. And after Dr. Salomon, it's going to be an amazing lecture. It's going to be a little bit more difficult, but he gave a great overview of the possibilities. And from this generalized talk, we're going to go into a very, very subtype specific different topic. So to all of you who are not doing neuro, and I know there are many people who are not doing neuro, this is going to be, I'm just going to give a couple of things to look into, and just to even see how you can go ahead with doing it. It doesn't mean that you have to know everything that's going on, but this is more of our experience. So we know that the development of the fetal cortex and the formation of sulci and gyri is a very orderly overlapped process. We try to differentiate it into three different components. First, the proliferations of the neuronal and glial cells in the periventricular area, then the migrations to the periventricular zone, and then once the neurons get into the cortex, then the organization. But all these processes we know happen at the same time, but we try to divide them this way so that we can identify them. So if we look at the different neurons, and this is just a schematic movement, this part is the ventricular zone, and you can see that the migrations happens, and this is even an older side, in the various layers, and the neurons kind of migrate in a very orderly way. Now we know that there are many more ways of migration, and this became a very complicated way of understanding it. This is from Perspectives in Biology in 2010. We know that the migrations is not only tangential, but it's also longitudinal, and there's a lot of various guidance cues here, and there's a lot of names. We also are now getting into the genetics of the names of the different proteins and the names of the different genes, and it's becoming really complicated. I'm not even starting to begin to understand what's going on. And I think our job as radiologists, and this would be true for if you're doing prenatal or postnatal imaging in malformations of the cortex, is just to describe it as nice as we can and try to not necessarily name it. If we describe the cortex correctly, then I believe that we'll be able to help the various genesis and to work out the different malformations. So first of all, it's important to understand the normal sulcation on the axial views, and as Laurent has showed before, we know the different various layers and the various names of the sulcations with age. These are axial images. What are we looking for in abnormal sulcations on MRI? We're looking for delayed or abnormal overlap sulcations. The fissures appear, they can be absent, or suddenly they can be too early when they appear. They can be abnormalic, asymmetry, and that is very important for the brain. Actually, it helps us in every imaging because it helps us in seeing if there's something abnormal by the symmetry of the brain. There is the operculum is a very important place. It's very important to look. There are many, many developmental abnormalities related to the operculum, and we know that there should be an acute angle between the overfolding cortex by age 24 weeks of age. There's a lot of abnormalities associated with it. There can be abnormal and incontinuous cortex and schizencephalies. And it's also very important to look in the sagittal images at the lateral ventricle. It can have all these bumps and subapentymal nodules, and of course the intraparenchymal nodules. So we're just going to touch down on a couple of malformations, and these are some imaging abnormalities, sulcations. For some reason, there's a lot of cortical malformations in Israel, and I think it's related to the use of prenatal ultrasound, which is very strong here, and I know in France too. And I think in the future we will sometimes discover that maybe ultrasound itself has some kind of connection with cortical migrations. I'm afraid that's going to prove at some point. But you can see here that there's an irregular deep sulci. You see that the cortex is abnormal all over. You can see and this is at 32 weeks. Look at this abnormality at 24 weeks of age. Even though we all try to say that we shouldn't make cortical malformation abnormalities at such early age, you can see by the asymmetry that there's abnormal malformation of cortex, and this indeed was shown to be a malformative brain. At 24 weeks, you shouldn't have these broad abnormal sulcations. These are not normal sulcation. And suddenly you can just see an abnormal gyrus just popping out, while it should be very smooth at 24 weeks of gestation. For 33 weeks of gestation, this is very abnormal to be so smooth and thick, and this is probably mesencephaly. Okay, so we'll try to go into the various groups. I'm just going to give you a glance at them. So we look first at the abnormal proliferation and apoptosis. And this group is divided into microcephaly and macrocephaly, and then into all the abnormal proliferation. So we'll just take a couple of groups. This is just part of the differential diagnosis of microcephaly today. Okay, I think microcephaly is probably the hardest diagnosis to make prenatally. You make it usually late in gestation, and the classical 38 weeks or 37 weeks walks into the womb, and suddenly they notice that she's falling off, and you have to, oh, is this normal? Is this part of the constitutional microcephaly? Is she like her parents? Or is this going to be a terrible malformation? And usually on MR, and there's a lot of syndromes, and it's a very, very complicated consultations to be done. Most of the MRs in this age group, you do not find anything. However, I'm going to show you just a couple of glances on some very severe microcephaly that we did find some abnormalities, just the subgroups. There's an extreme microcephaly with simplified gyral pattern, and of course this is a very rare abnormalities. Most of them should make the diagnosis before that, because they fall off the curves of the growth before gestation. And you can see at 34 weeks of gestation a very open operculum on the axial images. Actually, they did not make the diagnosis on these ultrasounds that were performed elsewhere in the north, but you can see that this is very abnormal for 33, 34 weeks. So I think you could have at least thought about it before. And this baby was indeed, this fetus, you can see the microcephaly in relation to the face. And this indeed was proven to be simplified gyral pattern. The parents were very religious. They did not want to stop the pregnancy, and he died after a few weeks. But this is not usually the situation. They don't necessarily die. This is a different situation, and this is the 38 weeks. This is like our nightmare. We noticed that the forehead of this fetus on ultrasound was flat, and they couldn't quite see the gyration on it, and it was not as easy to see it here. We thought maybe it was a problem with the skull base, but if you look closely, you can see that there is starting to begin a figure of 8 abnormality. You see here that the gyruses are abnormal. Look at the frontal horns on the coronal imaging are very important, prenatal and postnatal. They usually have a lot of relation to abnormal development, and you can see how abnormal the cortex is and the way the frontal horns kind of stand up. And indeed, this was, after a lot of thinking and multidisciplinary consultations, we had consulted them on actually performing a termination of pregnancy, and this is the pathology of this fetus, and you can see how abnormal the cortex related to it, and indeed it was an abnormal cortical malformation of microcephaly. Okay, this is a 5-week-old boy with spasticity and microcephaly. You can see how similar they all look. Look at the simplified gyral pattern. Many of them are associated with callosal hypoplasia or abnormalities in the cerebellum. In this case, the cerebellum is totally normal. Okay, but the microcephaly, as I said before, is a very difficult consultation to make. It's usually very late. Look for other things like hypogenetic corpus callosum, heterotopia, polymicrogyra. Look for additional, and the hindbrain is also very important to see. So usually you may see other abnormalities. When you don't have other parenchymal abnormalities, then we're really stuck. I hope the genetics will kick in and help us. On the other spectrum, we're still in the group of the abnormal neural and glial proliferation. We have many cases, a couple of cases of cortical hamartomas, tuberous sclerosis. We know that we make the diagnosis of the tuberous sclerosis by the heart, usually. And we are, however, sometimes asked in very religious families to evaluate the brain, even though there is no relation to the findings of the brain and the neurodevelopment of the child. We know that there isn't, it's not necessarily correlated. You can see the subependymal nodules, as you can see them here, and also the abnormal cortical tubers on the T1 axial images. You can see the hyperintense T1 subependymal nodules, and they may calcify. This is a very late age. This is a second pregnancy. In 2005, this MR was shown to have suspicious of tuberous sclerosis. It's a very old scan, so you cannot see, but you could also see the cortical tubers. And this was followed up elsewhere in a different institution, and everyone was following this tumor. And they were consulting it as the tumor and thinking of what to do and looking at it. And no one actually noticed, and this is very typical for us sometimes when we see a very big abnormality, not to look for other abnormalities and fetal imaging consultations. It's always important. And actually the cortex was very abnormal, so no one really thought that this fetal brain tumor was in the constellation of a missed cortical tuber. So, which really gave the prognosis much worse. I think had the mother known that this would be not only a tumor, but a tumor in a context of a tuberous sclerosis, I think the consultation would have been totally different. And this is postnatally, you can see the tumor, and it was indeed afterwards operated. Okay, so another abnormal proliferation